Good afternoon. Thanks for everybody who's going to tough out Friday afternoon and evening here. My name's Adam Wagshul. I practice with Summit Medical Group, mostly here out of Morristown, and I've been asked to discuss ankle sprains and fractures, which I'm sure you can imagine is a huge topic, and I have way too many slides, so I'm going to speak as quickly as I can, and I'll be skipping over some things to try to get us close to finished. So the goals for this section will be to recognize important anatomic and exam features in acute ankle injuries, including fractures and sprains, and Dr. Epstein certainly included a lot of my early talk and his talk, so we'll reinforce a couple of things and I'll try to bounce over some of those things. To understand decision-making for imaging and suspicion of fracture and understanding severity of injury in some acute ankle injuries, and to understand initial management steps for acute ankle injuries. Ankle sprains, as you've already heard, are incredibly common, up to 40% of reported sports injuries. Almost every ankle sprain will be treated non-operatively to its endpoint. Some ankle sprains will go on to have sequelae. Surgery is pretty uncommon, although it may be indicated for chronic pain, for chronic instability, or for associated injuries. We've seen a lot of this anatomy already. I would just draw your attention to the ATFL as being the most commonly injured ligament, and it's named after its insertions, the anterior talofibular ligament. It's tight in plantar flexion and it constrains inversion. So it's very typically injured in a step down into a hole or a step off a stair with the plantar flex position and a forceful inversion of the forefoot. Calcaneofibular ligament attaches again from the fibula to the calcaneus and is a constraint to inversion, and typically the ligaments will rupture in an anterior to posterior fashion with increased rotation. The deltoid ligament medially constrains valgus and eversion. It controls external rotation. It has superficial and deep components that have slightly different roles. The spring ligament, I think mostly we're going to skip over, but it can be associated with bad arch injuries. The syndesmotic ligaments, or the syndesmosis, constrains the tibia and the fibula together. So if you think of the talus as being wedge-shaped or trapezoidal, when you have weight on your foot, the talus is driven up into the ankle mortise, essentially splitting the tibia and the fibula, and the syndesmotic ligaments keep those two bones together to keep the mortise intact as a cup for the talus to seat. The strongest constraint to diastasis of those two bones is the interosseous ligament. And typically, with a forceful external rotation injury, these ligaments also will rupture in an anterior to posterior fashion. So lateral ankle sprains are certainly the most common. The ATFL is affected in at least 85% of ankle sprains and may be injured in isolation. There's discussion about whether the calcaneofibular ligament can be injured by itself. I don't know how you would distinguish that. But the ATFL is almost always injured in an inversion ankle sprain or in any sort of rotational ankle injury that affects the lateral side. It tensions in plantar flexion, so it ruptures with forceful inversion in a plantar flex position and with forceful internal rotation. It allows increased internal rotation, which then facilitates the subsequent rupture of the other ligaments. Risk factors include prior sprains, chronic instability, increased height, which you can imagine raises your center of gravity, increased weight, limb dominance, high arch. If you think about the mechanics of a high arch, it tilts you to the outside of your foot, sort of presets you in inversion. Poor shoe choice for a designated activity, even if that activity is walking in the street. Ligament laxity and slow reaction time to an inversion force, or what we call poor proprioception or poor body awareness of an unstable position. Typical ankle sprain pictures will always include things like lateral swelling and bruising, loss of the lateral skin wrinkles. Typically there's a history of a forceful twist or a fall. Pain should be primarily over soft tissue landmarks, not necessarily over bony landmarks, but these can blend, and there can be a combination of bony and soft tissue injuries as well, which we'll see later. Intolerance of weight bearing may happen early, and typically in mild ankle sprains it clears fairly quickly, but in more severe ankle sprains, intolerance of weight bearing can last several days. The exam should include a circumferential exam of the entire ankle, but we're really looking for specific tenderness over ligament substance and ligament insertions. Usually on the lateral side, can include the medial side. It's important to look for things that I think Dr. Epstein touched on. Sural and superficial perineal nerve stretch injuries or neuropraxia can happen with severe inversion injuries. The anterior drawer test, we'll have additional pictures of the anterior drawer test, is important to test lateral ligament stability. Typically it's done with the leg hanging, stabilizing the tibia, cupping the heel, and pulling the ankle anteriorly into an internal rotation position. If you're not sure about the value of the anterior drawer test. You can certainly examine the other side. I would say that's encouraged. And the same is true for talar tilt. Again, with the leg hanging, stabilizing the tibia, holding the foot in neutral dorsiflexion or in a little bit of increased dorsiflexion and trying to invert the heel will isolate for a calcaneofibular ligament injury. Also, it's easier to repeat these exam signs after several days of conservative measures. Ice, elevation, minimal activity, anti-inflammatory medicine. The exam becomes much more tolerable as the patient is recovering. So these are two basic pictures of the anterior drawer and the talar tilt examination. I would just emphasize this is a plantar flexed foot. It really probably should be a dorsiflexed or neutral foot to really isolate for the calcaneofibular ligament. Medial ankle sprains are rarely encountered in isolation, but can be encountered in association with other injuries, usually inclusive of the deltoid ligament. The deltoid ligament includes superficial and deep fibers. The superficial fibers resist external rotation and valgus, and the deep fibers resist posterior and lateral translation. So you can see on this anatomic picture, very big, thick, broad ligament with a large insertion on the medial malleolus and a large insertion including the calcaneus, the talus, even into the navicular, even into the spring ligament. So this is a hard ligament to injure, and an injury implies that this is a higher energy or more severe ankle injury. Risk factors include male athletes and valgus foot or flat foot alignment, and if you consider sort of the converse of what we said about the high arch foot, a flat foot alignment puts more weight on the inside of the arch, and it sort of presets the foot into valgus. So in a forceful injury, it will tend to fall into more valgus. Medial ankle sprain, again, the picture is as you would expect, medial edema, medial bruising, extensive tenderness along the medial side. It may include arch tenderness, especially if the spring ligament is involved. So for a superficial deltoid exam, I think these are very hard things to differentiate. Even in a chronic injury that's no longer painful, the superficial deltoid can be examined in sort of the converse of the anterior drawer test for the lateral ankle. So if you stabilize the tibia with the leg hanging, pull anteriorly on the heel, try to translate the foot anteriorly in the mortise, and try to increase external rotation, you can test for superficial deltoid stability. The deep deltoid is typically tested prone, trying to increase posterior translation, and I think it's very important to compare it to the other ankle. High ankle sprains involve the syndesmosis. We talk about them more than we see them, but certainly syndesmotic injuries, especially in college and professional athletes, have big implications because it's always anticipated that the time to recovery is going to be much greater. It's perceived to be a much more severe injury, and it has a much higher incidence of long-term sequelae. So about 10% of ankle sprains will include some degree of syndesmotic injury, and 20%, even when treated to completion, can have chronic symptoms. So this is, I think, a pretty good picture for a typical syndesmotic injury: forceful external rotation with the body weight pressing down on the foot, locking the foot against the ground. And you can imagine a sequential front-to-back injury of those syndesmotic ligaments you saw earlier. It's typically associated with dorsiflexion and external rotation. Can be associated with a fibula fracture, as Dr. Epstein mentioned, including a very high fibula fracture in the shaft, and it's important to include that part of the exam to feel up the fibula shaft for either instability or local tenderness that might lead you to expand where you would x-ray. Deltoid rupture, some form of medial injury, is also very common. So this tends to have more bruising, more swelling, a worse looking foot and ankle than a standard rotational ankle sprain. There should be a tenderness on the syndesmosis and even extending up the interosseous membrane into the mid-leg. The squeeze test is considered to be the most specific test for syndesmotic injury on exam. And the squeeze test is done by picking a spot higher than midway up the tibia and squeezing the tibia and fibula together. If it reproduces pain at the syndesmosis or at the ankle joint line, that's suspicious for a syndesmotic injury. And an external rotation test should be able to reproduce pain at the syndesmosis as well. So there are lots of different ankle sprain classifications, and honestly, a grade 1, 2, and 3, or a mild, moderate, and severe classification, I think is the best for just communicating general findings, even among orthopedic surgeons. Mild ankle sprain typically includes mild edema and tenderness, rapid improvement, usually good tolerance for weight bearing. Moderate ankle sprain may include some degree of instability or laxity on exam, but typically a recovery measured in weeks rather than months, and it may include some partial ligament tearing. A severe injury may include weeks of intolerance of weight bearing, frank instability on exam, and these are the injuries that may progress further to chronic instability and even requiring surgical management. There are lots of associated injuries with ankle sprains, and I won't try to give you a complete list, but certainly common ones include anterior process fractures of the calcaneus. I'll have a picture in a moment. They're almost invariably small. There are very few clinical implications. I think it's important to tell the patients when they have an associated injury, but I don't think this is one that would necessarily affect their outcome. And a lot of patients, once they know they have a fracture, presume that either their treatment would change or that their outcome would somehow be different. I don't think that's always the case for this injury. Lateral process talus fractures, on the other hand, if they're displaced or if they're large, may require surgical management. Fifth metatarsal base fractures may be completely non-displaced or may be significantly displaced and may require surgery. And we've seen some pictures of microfracture, bone contusion injuries, and osteochondral injuries. There can be associated ligament injuries, including bifurcated ligament in the hindfoot, the spring ligament, and as was already emphasized, I think it's important to examine the entire foot and look for associated midfoot injuries, including Lisfranc's ligament. So these are a couple of the associated fracture patterns we see commonly. Fifth metatarsal base, completely non-displaced fracture. Shouldn't really change the patient's outcome, but it may certainly affect their tolerance for weight bearing, and it may slow down their recovery in terms of functional activities, standing and walking, and it may even include additional bracing or cam boot use. Anterior process calcaneus fracture almost always heals, but a non-united fracture typically isn't symptomatic. And this is a fairly large lateral process fracture with some displacement, so that would require a lot of close observation and possibly even surgery. So there are some pretty firm criteria out of the Canadian health system for who should be x-rayed and the decision-making process. And I don't think it's necessarily a bad idea to have some framework, although it's also included in Dr. Steele's guidelines for the Ottawa criteria. The clinical judgment supersedes all of the above printed criteria, meaning if you're highly suspicious of someone, it's difficult to examine them because of pain or swelling or other factors, including intoxication, you can do very, very little harm with an x-ray, and an x-ray is indicated anytime you're suspicious of a severe injury. Otherwise, in an ambulatory patient, pain in the malleolar zone, and we'll have a picture of what the malleolar zone constitutes, but basically pain centered around the ankle associated with at least one of the following findings is considered hard criteria for ankle x-ray. And that would be bony tenderness along the posterior edge of the lateral malleolus or the medial malleolus or within 6 centimeters of the tip of the malleolus, and inability to bear weight for 4 steps at the time of the examination. So these are the malleolar zones, the area that's colored over in green, and the blue zones are the guidelines for 6 centimeters along the posterior border of the medial side, the posterior border of the lateral malleolus, and out to the tip. So including exam for bony tenderness along the navicular for medial fractures, the fifth metatarsal base for lateral fractures is all important, not in the formal criteria for who gets an ankle x-ray, and some of those injuries would be more detectable in a foot x-ray. So imaging should always include a standard 3-view ankle series, and I'll have a couple of pictures that can conceal fractures pretty well, especially if they're minimally displaced. On an anterior projection, we're looking for proper overlap between the tibia and the fibula, and appropriate spacing between the tibia and fibula in the syndesmosis. On a mortise view, or slightly internally rotated view, this space, the medial clear space, the tibio-talar space, and the lateral clear space should all be relatively symmetrical, and any grossly asymmetrical gaps should draw attention and may even draw you to request stress x-rays or other imaging. On a lateral projection, a displaced fracture may stand out, especially along the anterior border of the tibia. Mostly we're looking for the curve of the talus to match the curve of the tibia and not to have any abnormal translation. So this is a pretty benign looking anterior projection x-ray from my practice that has a little bit of a wide medial clear space, but really I think that's because the patient's foot's in plantar flexion, and a lot of painful feet will be held in plantar flexion. But here's a mildly displaced but very long comminuted multifragmentary fibula fracture that's sort of hidden in this anterior projection. So when you do order an x-ray series, if you are going to review it, I think it's important to review every image and make sure that you understand what each of the projections should look like. This is a talar tilt x-ray, which I think can be a good adjunct when you're looking for instability rather than fracture. And if you have a normal ankle x-ray with excessive tenderness and excessive laxity findings, I think a talar tilt can be helpful. I think a lot of the stress x-rays that we talk about are very difficult to perform acutely because of pain and swelling, and sometimes on a return visit or a follow-up exam, it's easier to obtain images like these. And it's very valuable to compare them to the other side because some patients will have abnormal laxity at their baseline. So sprain treatment, as well as fracture treatment, follows more or less the same template. And a lot of the early treatment is first aid, basically rest, ice, compression, and elevation, just like a Boy Scout handbook would include. Anti-inflammatory medicine for patients who can tolerate it, I think, is fine. Immobilization typically is only as long as the patient's pain requires. We definitely encourage early motion to avoid long-term stiffness, and I think it puts the patient also in the mindset that it's okay to move, it's okay to bear weight on an injury that doesn't include any strict contraindication like an articular fracture. Generally speaking, casting and prolonged immobilization is now discarded. There are definitely studies to show functional rehabilitation, early weight bearing, and early motion improves strength and improves sensory motor control. Rehab duration will vary depending on the severity of injury. So it may be very brief or it may be up to 3 months or so. And there are staged phases that the physical therapists will advance as the patient tolerates. But I think probably the most important point is at the bottom of this page. Other than maybe starting appropriate early treatment, patients should be reevaluated during their treatment period to make sure that they're really meeting goals, meeting milestones, and if they need additional imaging or initial treatment, that we should push them in that direction. Immobilization can be in all different forms. I usually start patients in a cam boot if their injury is severe, or in a lace-up brace if it's relatively mild. I don't find these air stirrup braces to be very well tolerated after a couple of days, and they're hard to wedge into a shoe. So for patients who want to attend school or go to work, I think it's hard to wear a stirrup brace. So I have a couple of quick MRI pictures of ruptured lateral ligament on a coronal view versus an intact lateral ligament, this normal thick black band from the fibula to the talus. Here's a dislocated peroneus longus tendon with a ruptured retinaculum with a brevis in the proper location behind the fibula, longus dislocated, and here's a brevis tear with an intact longus. I'm getting the signal from the back that we need to move forward fairly quickly. So here's an osteochondral lesion of the talus and some bone contusion injury with a lot of edema in the talus. And those injuries can last up to 6 months or sometimes even longer, can be very discouraging for an athletic patient. Instability can be treated with surgery. I have a couple of slides to show what that surgery may look like, but I don't think it's going to help the decision-making. If a patient doesn't meet proper milestones or has long-term instability after ankle sprain, this should probably be referred for consideration of surgery, and typically we would do MRI imaging for that patient. This is a quick intraoperative picture of what looks like a mogul inside a field of snow, and this is an osteochondral injury similar to the one Dr. Epstein showed, and this is a metal probe lifting a large sheet of cartilage off what otherwise looks like a fairly benign injury. So all that cartilage would be debrided out arthroscopically if necessary during an ankle stabilization procedure. And these injuries can be chronic, and here's a big cystic change inside a talus that can account for chronic pain in a patient who otherwise has a very, very normal exam and very few findings. Fracture anatomy, I think Dr. Epstein also ran over fairly quickly. There's a huge range of ankle fractures from very large, complex fractures requiring a lot of open reduction technique and large metal implants, and relatively benign, minimally displaced fractures that can be treated non-operatively. Fracture, we assume, is going to have a worse looking presentation, but that's not always true. Here, fracture blisters are important to recognize. The implication is a lot of severe edema from inside out. That doesn't mean a bad splint was put on. That's because the severity of the edema is separating or delaminating skin layers. Typically, we expect to find bony tenderness rather than soft tissue tenderness. General alignment, crepitus over bony landmarks is important to look for. Neurologic and vascular exam is very important. There are very few surgical emergencies other than an open fracture in this setting. But if you do find a dysvascular foot, you'd be doing the patient a favor by referring them for hospital care. Combined soft tissue and bony injuries are very common. These are, again, the Ottawa criteria. And there are lots of ankle fracture classifications as well. I think the only one that's really very helpful in short for an ambulatory setting is to recognize the small, minimally displaced distal fibula fractures that can be treated non-operatively with weight bearing. This is sort of a maybe zone where a displaced or an unstable fracture could require surgery where other fractures wouldn't, and a high fibular fracture should always draw suspicion of the syndesmotic injury indicated here in red. Fracture treatment initially would be the same as sprain treatment: rest, ice, compression, elevation, and mobilization for as long as is required. Non-operatively treated fractures, certainly minimally displaced, can be treated non-operatively, and surgically treated fractures here with a widened deltoid ligament and a minimally displaced fracture can be treated with surgical management and early range of motion. Syndesmotic injury with syndesmotic stabilization across the tib-fib joint. And there are certainly bad sequelae of late treated or improperly treated ankle fractures that typically correlate with the degree of reduction or how well the ankle is aligned after treatment, although even a well-aligned ankle with a severe injury can go on to arthritis, seen here. And lots of pages of references if anyone would like to review them later. Thank it's late. Okay. Well, I think an MRI is a great preoperative study, and I see a lot of MRIs on people who have had a primary ankle sprain with short-term symptoms, and I don't think it helps very much in decision-making. So when a patient initially presents, I think a good history and a good exam is key, and I think you've heard that before. But examining for soft tissue findings, I think, is important early on. So if a patient really doesn't have bony tenderness, doesn't have a real guarding against weight bearing, and has good function, their treatment should probably be initial immobilization in a functional brace, not necessarily a boot unless it's severe, early weight bearing, maybe physical therapy, or at least a follow-up visit, maybe in the 10-day to 2-week mark, to see how they're progressing. If they have early trouble or if they have reproducible bony tenderness, I think it's fine to order x-rays. And the MRI for me is late. The MRI is for someone who doesn't meet their goals in a month or two, or someone who has frank instability that doesn't improve, or mechanical symptoms, something clicking or popping where I'd be suspicious of a loose body or an osteochondral injury. Okay. Well, normal activity for someone who's a once-a-month tennis player. A nurse, you said? Okay, so for someone who stands 8 hours a day, that's a certain type of patient, and it's very hard to get back to that if there's significant bone contusion or if there's anything associated. So ankle sprains are such a huge spectrum that there are people who sprain their ankles and are back at soccer practice in several days, and I know that's not who you're talking about, but that's just an example of how big the range is. So I have patients with significant talar contusions who take 4 to 6 months to get back to a full day of standing. That's way at the high end of the spectrum. 2 weeks is a good guideline for someone who has a very, very simple sprain. But I don't think that it's an easy day to get back in 2 weeks. So it's very individual. Someone who stands all day and lifts all day and paces the floor all day has to insert some of their own judgment in my practice. So people who tell me they can't do it, I don't try to force them back. People who tell me they can do it may limp and may tough it out, and it may just be a couple of weeks of recovery. Other people, maybe up to 3 months. Okay. Do you want me to take more questions, or do you want to move ahead? Okay. A 3-view ankle series should be a very self-explanatory set. Yeah, it shouldn't be mysterious, and if you ever do get a question, it's an AP or an anterior projection, a mortise, and a lateral. But any X-ray handbook should include all of that, and yeah, it shouldn't draw a question.